Khariz.
Good morning, panelists, judges, and audience. My name is Khariz Fahrurrozi. I'm going to present our case titled, Is it Nodal or Infranodal? Diagnosing the cause of cardiac syncope of a 70-year-old male with a 2-to-1 bifascicular block using a troponin test. A 70-year-old hypertensive male was admitted to the ER due to bradycardia and chest pain relating to his left shoulder and back in the last 24 hours. While his chest pain now subsided, he also reported that he had 2 episodes of syncope yesterday. We performed a 12-lead ECG, and this is his initial ECG. We can see that this patient is bradycardic. He has a normal PV morphology with a 2-to-1 conduction, and he also has a prolonged PR interval. We can also see a bifascicular block with a complete right ponder branch block and left anterior vesicular block. To better appreciate this ECG, this is the letter diagram. We can see that the heart rate is 35. We can see 2 P waves highlighted in yellow and 1 QRS highlighted in red. We can see prolonged PR interval and also a complete right bundle branch block with a duration of more than 120 milliseconds. This patient has a normal echo and negative troponin test. The question is, in the presence of 2-to-1 block in our patient, what is the underlying cause? A, it's most likely a nodal block. B, it is likely an infranodal block. C, probably cardiac syncope and be blinded CT scan, or D, more tests needed. The answer is D. A 2-to-1 block is clinically ambiguous because in Mobitz type 1, we can see that there is a progressive PR lengthening, or in Mobitz type 2, there is a fixed PR interval followed by gradient drop. However, in a 2-to-1 block, we cannot assess any progressive PR lengthening because every other P wave is blocked. So in this case, how do we determine whether our patient has a nodal or infranodal block? We can do some tests. In our case, we perform an atropine test, and this is the ECG after we give him a 1 milligram of atropine. We can see that the 2-to-1 conduction is now gone, and it is now, the patient now has an AV dissociation with a ventricular escape rhythm, and we can see that this proves that this patient has an infranodal block. Why atropine works? So exercise and atropine will improve the epinodal block because they decrease the fecal tone, but it will worsen the infranodal block. If we have a patient with a nodal block, when we inject atropine, it will speed up the toll walker and it will restore the 1-to-1 conduction. However, with a disease HPS, His-Purkinje system, when we increase the conduction, the impulse will bombard the HPS system. Instead of improving the conduction, the impulse will pile up and crash at the bridge. Therefore, it will worsen the block and cause a total AV block. There are some clinical signs that may help us as a GP at the ER to determine whether our patient has a nodal block or infranodal block, such as the QRS duration, PR interval, escape rhythm, and also we can do some tests like atropine test, exercise test, and carotid sinus pressure. However, we should also do serial ECG to confirm whether our test is right or wrong. The take-home message is that we have to treat infranodal block as a dangerous entity because they can progress to a high degree of AV block, and tests are useful, especially in the ER, such as atropine test. And lastly, pacemaker implantation is indicated in our patient, especially for those with symptoms like syncope or ptosis. Thank you very much for your attention.
Terima kasih Dr. Khariz untuk presentasinya. selanjutnya dari mana?
Sudah semua? Baik. Boleh memulai?
Nggak apa-apa.
Ya, mungkin
Udah, nggak apa-apa yang lain. Nggak sejauh-jauh nggak mungkin.
boleh mendekat ya. 3, 2, 1.
Ya.
3, 2, 1. Ya. Baik, terima kasih. Para peserta disilakan untuk istirahat, sholat Jumat dan juga makan siang, dan akan berkumpul lagi di opening ceremony mulai pukul 13.30. Terima kasih.
Sukses ya. Sukses ya. Dingin loh, selesai. Selamat datang.